The overdose crisis cuts across the entire United States. People are dying across urban regions, across rural regions. But I think the key thing that every physician everywhere needs to know is that we all need to do our part to address opioid use disorder and to provide treatment in our practices.
We need to understand how to screen, understand the medication, and break our own bias and our own stigma so that we can have these conversations.
There is a component of the medical history, getting who are you? When you're asking about things like medications and allergies and symptoms, that's like the real part of the history. But this social history gets pulled out. Marital status, educational status, living status, and drug use. It goes in that pile. So from day zero of medical school, you have this idea that drug use is somehow a social condition, not the body and not primary care and not medicine itself.
Every day was a day that I could lose my son. And I'm a primary care provider, and I don't know what to do for my son. We are in a model of healthcare where the primary care is the hub. We should be the first place somebody thinks about, like, that's who could help me.
In a clinical setting, the most important thing that we can do for people with opioid use disorder is to be able to offer them the most effective treatment, which are medications.
There are 3 FDA-approved medications: methadone, naltrexone, and buprenorphine. These medications are, quite frankly, life-saving.
We have data telling us that there's low uptake of prescribing these medications and that people are really undertreated. Until recently, providers had to receive a special waiver to be able to prescribe this medication. Now, anyone can prescribe.
A lot of clinicians I speak to are worried that it's too complex for them to be able to do in their practices. They feel like they need counseling or therapy on site. First of all, there's a lot of great resources to help support people who are trying to learn this. And second of all, we prescribe complex treatment regimens all the time, and this is actually probably on the easier end. Opioid use disorder in this time, in this year, is a deadly diagnosis. We all need to be a part of the solution.
Opioid use disorder is a diagnosable condition. There are 11 criteria that are in the DSM.
I think of them as falling into 3 big buckets. The first bucket is physiologic changes, meaning tolerance and withdrawal. The second bucket is loss of control. People will spend excessive amounts of money on drugs. They may spend lots of time during their day using drugs or seeking out drugs. They may be having cravings all the time in such a way that they can't go about their lives. And then the third bucket is negative consequences. So their relationships have started to deteriorate. They may not be able to perform as well at work, or they may drop out of school. And so they're starting to have opioids affect their normal functioning.
It's really important to note that for people who are prescribed opioids for chronic or acute pain, they will develop tolerance and they will have withdrawal symptoms.
I'll get consulted by other doctors who are worried that a patient who's taking daily opioids for the treatment of pain has an addiction to an opioid. And the key thing that I always want to try to understand is, does that prescribed opioid make them more or less functional? Somebody who's using an opioid daily that's being prescribed to them for treatment of chronic pain might actually find that their functionality gets better when they take that opioid. That's not addiction. That's a medication helping a patient.
In that case, we do not diagnose an opioid use disorder.
It's well documented in the literature that there's stigma. We don't want those people in our practice, or our other patients wouldn't be comfortable if those people were in our waiting room.
When I would meet doctors, I always felt a lot of judgment. You're treated, like scum on somebody's shoe.
You can judge us, but don't judge us in a way where you don't care for us.
There's the way that people are treated, and there's also the harm of the systems of care. But if we address the harm on multiple levels, we can actually invite people into a whole new level of well-being.
Building trust is the biggest thing around this whole ordeal.
Every encounter you have with somebody who's using drugs, you're reducing the harm. It's how you treat them. You make them feel seen or heard.
There is upfront work that we really have to do to not just say you can trust us, but really act in ways that prove that we are going to be there.
One of the things you can do is actively signal that they're safe with you.
You can have posters up about preventing overdose. You can also open the door to those conversations in screening questions.
Even just having a box of Narcan in an office setting that's visible signals that you're ready to have a conversation with folks and that it's okay.
The single most important thing that I try to understand when I'm meeting a patient for the first time is how ready are they to stop in that moment? And if they're not, it's my job to still engage with them and still provide them the many things that we can still offer them, even if we're not providing treatment for their addiction in that moment.
I remember being hospitalized and my doctor came by and she had a recovery coach shadowing her, and I was able to chat with her for a little bit. One thing that she said to me that's always stuck with me is that you get sober when you're supposed to if you live long enough to let it happen.
A key centerpiece of a lot of the counseling that I do is naloxone, making sure that they have access to the overdose reversal agent that can save their life.
In addition to that, there are some tips that we can offer to people about trying to reduce their risk. Things like don't mix substances, never use alone. We talk to our patients about the different ways that they use drugs to ensure that they have access to sterile works to try to reduce the risk of infection.
Wound care is a core component of reducing the harm of the way drugs are used, but it's also a really great, simple way to get into relationship with someone and start disarming the harm of the system itself.
I don't think I would have stopped if I hadn't encountered the doctor that I now have. She just said, I can support you until you decide that you want to do something about this. And so when I was ready, I was able to call her.
Once you start taking care of people who have opioid use disorder, you realize this is really rewarding. This totally can be within my scope of practice and is actually not that different than taking care of people who have other conditions. If I have a patient and we're talking about medication choices, I first ask them what they know about the different medications and what they've heard so that I understand what their experience may have been with these medications, either personally or friends and family. And then we talk about the three medications.
There's buprenorphine, methadone, and naltrexone. Naltrexone is an opioid antagonist, meaning that it binds to the opioid receptor and blocks other opioids from being able to bind. So the way that it works as treatment is it keeps somebody from experiencing the positive reinforcing effects of using opioids. But it's not treating withdrawal symptoms or cravings. Naltrexone comes in two formulations, a daily pill or a monthly injection. It's very important that somebody not have used opioids for several days before we start naltrexone.
Because it is an antagonist, you're not going to develop a physical dependence on it. What we hear from patients and sometimes families, that it just sort of seems like a safer medication. You know, I understand that and want to validate that that's how they're thinking about this. I try to reframe it and think about, like, we should be thinking about the medication that is most potent when it comes to mortality benefit, and buprenorphine is that medication compared to naltrexone.
Methadone and buprenorphine are both opioid agonists. They bind to opioid receptors in the brain and have an effect. And the effect that they have is to decrease cravings to use opioids, as well as reducing withdrawal symptoms. Buprenorphine is especially important for clinicians to know about because it can be prescribed in any medical setting and is readily available to all of us. There's an injection that can be given, is most commonly given as a daily medication that's given under the tongue.
If we're initiating treatment with buprenorphine, one of the most important things that we can ask is when was the last time that they used an opioid. We use the COWS scale where we can collect objective data and then start when someone is in moderate withdrawal.
Sometimes for fentanyl, it takes a little bit longer before somebody goes into the kind of withdrawal that we need them to be in before we start buprenorphine. But the bottom line is you want to make sure that they don't have any other opioids sitting on the receptors in their brain. And then you want to give them this dose of buprenorphine and see how they respond. Increasingly, we're starting it at home. Often we'll start with 2 milligrams or 4 milligrams. They should notice that their withdrawal symptoms are being treated, that their cravings start to go down, and most patients will end up on a dose of 16 milligrams daily. A lot of families and clinicians will tell me that they're worried that when somebody has a medication like buprenorphine, they'll divert it. But studies show us this is not as common as people think that it is. Buprenorphine is a life-saving medication, and so it's really important that we continue to prescribe and not hold back simply because we're worried about diversion.
When I think about the goals of treatment and offering people medications, it's offering them a chance to take medication that allows them to focus on their recovery, focus on the other goals that they have. Because it is really hard to focus on anything else if you're having significant cravings.
The medication gave me enough of a foundation so I was able to access other supports. I was able to, actually participate in therapy instead of showing up 2 times and never showing up again. For the first time in my life, I was able to hold on.
There is a continuum of recovery that happens beginning even with harm reduction itself. Recovery happens any day someone shows up and is able to even ask for help.
I'm hope. I made it through. That's what doctors need to see, that I'm hope.
Recovery really is happening the first day somebody believes that they can be well.